Okay. So we are working, and I'm happy that I'm working with Ahmed because we are doing this lesion together. We are mid in the rectum. It's a lesion estimated around 5 to 6 centimeters. What do you think?
Yes, I think
more larger, yeah. And I'm working under saline, as you can see. And now I'll show you the strategy. Okay, stop, close.
So you can for us. You can hear.
Yes. Okay. So the lesion was, because I'm already healthy, was this big LST granular mixed type with this nodule. So what I did, I was checking at first the position. The patient is in left lateral. I'm working with a gastroscope 2.8 millimeter channel from Fuji film, 700 series. And I was working at first in retroflexion to make the mucosal incision to get the access in the submucosa in this way. And then when I was deep in the submucosa, I came back in frontal vision. Still, Ahmed, we have something bleeding a bit, but it's a small one, it's a mild one. Yes. Then I came back, I make the mucosal incision from the anal side. I will show you in a while. Here we are. Here. Okay. Then I enter in this pocket or tunnel, and step by step I made the dissection, reaching the exit. That was the other one, in this way. So now I'm able to connect the lateral part that could be done in retroflexion, as in this case, because I'm very stable, or in anterovision, whatever you want, because now you're stable and you are free to move in any kind of direction. So you know that working under saline, here we are maybe, because we are looking for this small vessel bleeding from before.
Looks like a network here, but
yes, like, let's see here. At first I will inject. Ahmed is helping me having continuously water to have more coagulation power. And step by step, I need also to remove this one.
Can you run us through what instruments you're using?
So as a scope, is a Fuji film scope, 700 series. As a knife, I'm using an hybrid knife, Flex T-type 2.0 millimeter.
And for rectosurgically, you like to use Swift coag, you tell me.
Okay, we have a lot of water coming out.
Okay.
So we should take care there. And I think that this afternoon I need to go for shopping for new pair of shoes, because all the water is on my shoes.
And then can you run us through what your injectate is? Is this saline with methylene blue?
Yes, exactly. We are injecting only saline. You know that with the hybrid knife Flex, it has been demonstrated that you can use also some other viscous solution other than standard saline, but let's say by what the company is suggesting, you should inject only saline. So we had some drops of methylene blue to have this coloration of the liquid we are injecting, and stop. We didn't even add any adrenaline, so the use of adrenaline is a little bit controversial.
Yes.
Because it's not really help you in avoiding the late bleeding. It's just to have a nicer view during your dissection, but no more than this, honestly.
And even if used, use very, very low concentration is also used.
Water, thank you. So in this technique under saline, you need somebody, in this case is Ahmed, who's taking care of the water all the time, and is adjusting, go with water. So here, for example, I want to make hemostasis, so I need the saline continuously to have, as you can see, more coagulation power. When I want to dissect, it's stopping sending water, so I can make the dissection.
And you use Swift coagulation 4.5 for this. Okay.
Yeah, I didn't change the setting. I'm using right now, up to now, let's say, then we'll see what will happen. Same knife, same setting, just adjusting the saline.
Okay.
So here, Yeah, if you are able to check and make a preventive hemostasis of any vessels, yes. In case you have a very massive bleeding, you know that under saline the field will become all blood. So you must be quick enough to start coagulating and a little bit lucky sometimes.
Yes.
Otherwise, you have to shift to or CO2 or to take a coagrasper. But nowadays, because you know that under saline, under a solution, the magnification is even higher. So if you go and work slowly, very carefully, you are able to address every single vessels, most of all. This means that you can make the hemostasis prophylactically instead of make the vessel bleed and then go and try to coagulate it.
Now it's a very nice view how you go over a fold and go down, because usually the muscle is not a straight point.
Yeah.
So you move up and down, avoiding the muscle, and keep dissecting in submucosa.
Okay, here we have a vessel, for example. I will inject it first, and then I'm not changing anything. Just continuously saline, and I'm coagulating. Okay, stop. A little bit water because it's dirty, just for this reason. Okay. Now we have mucus. What is happening here?
Roberta, can you hear us?
Yes, now yes, better.
We're watching a piece of art here rather than a procedure.
Ciao Pradeep!
The way you're doing is so smooth, hardly any stress in the room, everybody's enjoying.
Because before having the line we were singing.
It's fantastic. This is where expertise shows, is when your movements are so small and things are happening. Can you tell us, are you using a cutting current when you're dissecting, or and change over only to coagulation when you have a vessel? Or are you using swift coagulation all along?
This is Swift. I'm doing everything with Swift Coag 4.5. Everything. Just sometimes, you know, after, for example, here they are coagulating, when there is too much fibrosis, you see that the tissue is becoming whitish. I can use, for example, now cut. But all...
How come you don't have that many bubbles? Normally...
It's because he's doing a great job.
Oh, he's pumping.
Exactly.
Yeah.
He's adjusting the pedal of the pump depending on what I need, because you know he's expert, so he knows what I need in that moment. If I need continuous pump and it means I need to coagulate or not. This makes the difference. So at the beginning, because we are not used to work together, we were adjusting on what we need, but now I'm not even saying a single word.
It is not about your skill.
No, it's a team skill. So even, you know, I use not to touch the device. I just ask the second assistant here, thank you, to just open and close. And at the beginning I was asking. Now I'm not asking anymore. She knows that when I'm not cutting or dissecting, I need the tip of the needle in to be able not to entrap any tissue. Okay. I think we're almost done.
Yes, on this side.
Let me check. Close, thank you.
And now you did retroflexion while you are inside the tunnel.
Yes, I like it.
Okay, good.
Because it's an extra traction. What Ahmed is telling is that I was entering the tunnel, I was exiting from the tunnel, and I was retroflexing. So you can see that the scope is coming
very
from
nice
inside the
stretching,
lesion.
yes.
So you have an extra traction from here. So let's check how much we miss here. Just a little bit, okay. But do it very gently, because you can break. You can break the lesion. Yeah. Open. And even for the first injection, I didn't use any extra device rather than this knife. So now I will make the final mucosal incision, and I will connect all the tunnel that I've done. A little bit of water just to check where we are. Okay, we have a bleeding. First I will inject. Okay, stop. Okay.
Okay.
Thank you. I know.
So, just a question for the audience, not for the expert. So, when I see a lesion like that, more than 6 centimeter, as a general gastroenterologist, endoscopist, when I say I should refer it to you, when I say no, tell me what is our guidelines here?
Do you want to make any comment meanwhile I'm
Yes,
cutting?
he asked about indication for
Yeah.
ESD for such lesions. When he see a large lesion in the rectum, when send for ESD, when do other intervention like surgery or EMR.
So nowadays we know that the clear indication for the rectum, whenever if technically possible, is to remove the lesion and block. Because we have data that in the rectum you can have an higher chance to have submucosal invasive cancer compared to the other tract. Although we have a paper that was published last month, I think, from the France group, that they say that it is not true. And in the rectum you have the same chance of submucosal invasion than the other part of the colon.
Okay.
But it's the only one. It's the first one, is the only one. So, and our guidelines are based on all the other study, not on this one. So,
In general, ESD is better than EMR in the rectum?
although unless EMR is for en bloc, so for less than 20 millimeter lesion, yes, ESD is much better because you need to remove the lesion en bloc in the rectum. This is the message. It's not the technique, but the en bloc.
Yes.
So what you achieve. Okay, don't.
Just when you see blood vessels during your dissection in the
Yeah.
mucosa, when you decide that you will use a core grasper or just the tip of your catheter, there's a specific size that you use to...
Let's say that you should compare it with the size of your knife. So when it's much bigger, although size estimation is not perfect, let's start with the preventive coagulation, so prophylactic coagulation, as I was showing, and in case I will find another vessel, I show you again. Otherwise, if you don't feel confident, you can proceed and take in a coagrasper. But try to estimate this before making it bleed. Otherwise, your field of operation will become completely red and difficult then to manage. Then you know that the panic comes, all the team is in panic because everything is red. Very good. Beep, beep. This one.
Very nice.
But we still have the other side, and I think I need also to, yes, to make the
Just get a
mucosal
round of
incision.
applause from the audience for
Open.
the case, so that was great. Thank you.
So when you work underwater, you don't keep a lot of mind for the gravity.
Not really,
Yes.
but I'm always checking the gravity under CO2 before, because in case I have a massive bleeding, sometimes I need to shift to CO2, and in that case the gravity will make the
Will
difference. So if you are ready before with the gravity, much better.
Okay.
Where? Here, open.
Question to you and Dr. Madkour. So, do you guys notice using the water jet may decrease the efficacy of the coagulation during dissection, or no? And do you really increase the settings to overcome this?
So as Roberta say, it's a matter of what you're doing. So if we want a pre-coagulation, we use a lot of saline, so it looks like a soft coagulation. So you pre-coagulate. Then if you want to do cutting, we don't give a lot of water, so it works like a swift. So we don't change the setting, but we change the medium. If it's saline, a lot of saline, few saline or CO2. Usually accessing the submucosa is the most difficult part. So even here, after finishing all this, we still need to access submucosa after incision here. So we need to be meticulous, take care of the muscle and work. And she may continue working from retroflexion or moving to forward. But take care for accessing submucosa, not to have a muscle injury at this time.
Okay.
Yes, here what you ask for.
Close.
So this was like a large vessel, not so large, but like a medium-sized vessel.
Open.
So what we do, we use a lot of saline and flush more, and she used the same setting, swift coagulation 4.5. But here it's called do like icing. It turned white and now pre-coagulate. Now I stop flushing with saline and they use the same setting, but she cut.
So when you see the spike, this lightening, it means that you are dissecting.
Yes.
When it's flushing continuously, he will prevent like in this case, is preventing the spike. You won't see any spike and you are more coagulative. When you see spikes, you are dissecting. No spike, coagulating. This is the rule.
So my question to you again, the rectal area, we see a lot of hemorrhoids, rectal varices, and we see a lot of vessels there. You are not, when I see some reddish things, I try to be cautious. So if the patient has got rectal varices and or large internal hemorrhoid, does that preclude you from doing ESD?
No, but you have to be more careful for sure, because you know from the beginning, sometimes you find viruses inside, but you can't see from outside,
yes.
And you manage it. So it's not a contraindication, but you must be very skilled. So don't start with that type of patient. This is where we are here.
Also, the guidelines recommend to start ESD in the rectum, but not on dentate line. Okay, so when you start, don't do such lesion, but after a while you can still do. What?
This is a very...
So the best one to answer this is Roberta.
So we are in the... Let's consider some factors. We are in the rectum. Then the second factor is the comorbidities, to try to score the patient, and to try to understand if she has to take back soon any medication. I'm sorry, I have all the water coming down, and is all my...
Can we clean this? I'm sorry.
And also the technically possibility of doing it or not.
So your decision different according to the location, Roberta?
Yes, also. I mean, in the rectum usually we are not so keen in closing.
Okay.
In the other location of the colon, yes, but even there it would depends on the extension. The more you are going to circumferential, the more it's difficult and also tricky but complicated, because you can cause strictures. So there are a lot of factors. This specific one I don't think we are going to close.
Yes, sure.
But before answering, I want to see the base. I mean the bed of the resection. I can't say. Are you open?
And also, you will look for if he have an anticoagulation, if he had to have anticoagulation back, it may be different in decision.
Exactly. It should be almost at the end. Okay.
They ask if you think he should have an MRI for those patients before going for ESD?
Usually at home I do, I tell you. Because in case we were not good enough in making the optical diagnosis and it comes out to be an invasive cancer, that one was the baseline.
Okay.
Not to guide so I don't do it to guide my resection and my indication and to understand if doing or not. That one is only the optical diagnosis, the size, the scales. It's not the MRI. The MRI is for the oncological part.
Nodal, if there is.
Yes, nodes,
nodal.
the nodes, yeah.
Nodes.
What do you think?
Yes, also we depend on MRI or rectal EOS only for nodal assessment,
Exactly.
not for the mucosal assessment. The endoscopy is more accurate in mucosal assessment.
So what about the use of the thermostat after the procedure?
Yeah, that one, even more in case you are not going to close it, can make the difference. So that one I'm sure I'm going to use it. Let me go again there because I lost. Okay, I think it stopped.
And do you usually give rectal steroid to patients after rectal ESD to prevent stricturing?
No, just if it's just if it's circumferential or almost two-thirds, almost circumferential. Although we internationally we just have a paper accepted on the risk of circumferential stenosis after circumferential resection, and we also in Western series demonstrated that there's a risk even in the rectum. So we thought for a long time that the rectum was very forgiving because it's a large ampulla and you can't have stricture, but it's not true. You can have stricture also in the rectum. So we still need data to understand if we can prevent and make some prophylactic measurements as the steroids per annal, it will work or not. I don't know.
But I think if it happens in rectum, usually it's very responsive to 1 or 2 sessions of balloon dilatation. The problem usually in esophagus, but in colon it's not a big issue.
So in your experience with this rectal size lesion, what is the chance that it is 100% cure ESD in this lesion, in your experience?
This lesion, like this one, 100% because it's too big to remove it and block AMR.
No, he mean how many times usually you have R0 after ESD?
Sorry.
Like curative resection. After ESD, no need for more treatment.
Allora, laterally R0 is depending on technical skills.
Yes.
And deep R0, let's check. Now it's difficult to make the assessment because the lesion is already disconnected from the submucosa, but we were looking at the nodules and the lesion. It's no more than Genet 2B.
Yes.
So it seems still an adenoma, maybe an advanced adenoma, but no more than this.
Yes. And I think the accuracy of this assessment is more than 86%.
Open.
Your endoscopic assessment, and it depends on the size of the lesion. In such lesion, I think it's we have a very low incidence to have like an invasive cancer in such lesion. So the questions, the other question from my side. Yes, but usually the depth related to the size and the assessment. If it's very large, sometimes assessment is not accurate. But for sure, the depth is the main point. But when it's larger, we have more incidents to have like a missed foci of invasion. So the question I think I hear to Dr. Baradib, he is there, and also for Roberta, because this is a very debatable point. If after resection for such lesion, we have like a deep invasion, more than 1 milli, with all other signs are good, like no lymphovascular invasion, no perineural invasion.
Wait.
I think this is the last cut.
Yeah.
I think the last cut. Now let's show this and go and come back.
They went. Are you here with us?
Yes. You still here, or we?
Yeah, just 2 minutes, and I think we've done.
We have. Okay, it's just the last cut, I think.
I don't know why now we have.
Can you hear us? Right? Yes. We are live. Okay.
Open.
I think this is the last cut, right?
Should be.
I see, it should.
Even if it's the last one, we should still stay focused and don't lose concentration, because you can make mistakes and complication even at the last cut.
Yes, sure.
So there's not a step of this procedure where you can really relax.
Yes, it's not a matter how fast, but how safe and effective you're doing.
Okay.
Yes,
I think we'll
you're
move
done.
it. Okay. Open. Now I will go.
So you will move to other room, okay?
Okay.
I think you do coagulation and they come back to you if you want. Okay. You're very nice.
Sorry.
Sorry for
I made
that.
a mistake.
No.
I'm very sorry.
No.
I forgot we were here.
No. Okay.
I'm European, I'm sorry.
No. Why you say this? Yes. Yes.
Open.
Okay, if we go for the answer, it will depend on the histopathology. If it's an adenocarcinoma and it's a curative, like T1A cancer, and that was confirmed by another pathologist, we follow up like a cancer rectum patient to have a cancer rectum and they do surgery. But if it's not, and if it's just intramucosal or high-grade dysplasia, so we do the follow-up. Usually we do after 3 to 6 months, but I think Japanese do after 1 year. Can you hear us, or I'm not sure?
They hear us, but now we don't hear them.
Okay, so can we hear them? So if you hear us, we can't hear you, but we will go for peristat now. After doing underwater.
Dr. Ahmed
Yes.
So we have seen now the bed of the resection.
Okay.
Would you recommend to close it or no?
We answered before, but because he is Ahmed, we will answer again, Roberta.
This is,
Answer again for Dr. Ahmed.
Yes, we will. We must. We must.
see this one, this is more than half. So endoscopically, the only way to really close it with suturing.
Okay.
There could be, nowadays we only have the overstitch or the suture art. So it's long,
Okay.
expensive, but this is not the important thing. The important thing is the patient. In the rectum, there's really not a huge indication for closing. I have some small bleeding from trauma here.
Doc, this is catheter.
This is catheter for prostate.
Yeah, okay.
Yeah.
So you can hear the answer, or it was not clear?
I won't close it.
Okay. So because it's a rectum, and we have a nice resection bed, we will not close.
Of the thighs, the admission of the patient is almost like
Try, because we have a small bleeding. Do you already prime it?
they keep
Okay.
closure, the cost of the closure.
I will push now, ha?
Go.
I think it's time to change the practice.
Yes.
Also the ESD patient
Nalagyan, Doc, ha?
in the hospital 1 day or 2.
Prime already.
Okay.
This is the
How much did you give me? Give me a bit.
Yes. So, but what good now we have a different options,
Okay.
different closure device,
Stop.
and the decision depend on the patient and the lesion and how the procedure
Go.
gone. If it was straightforward, nice procedure like this, or if
Go,
we
go,
have
go, go.
some
Go,
suspected
go,
thermal
go.
injury for the
Go.
muscle, or if we have already some defect, all these make the decision.
Go.
Going down.
Go.
Going.
And now Roberta applying the peristat to decrease the incidence of delayed bleeding, because here we have two risk factors.
Go.
We have lesion more than 4 centimeter and in the rectum. Those are risk factor for delayed bleeding. We hope this risk
Okay.
decreased after precoagulation and applying the
Can I
peristat.
have one more?
And now I think we done. Yes, Roberta, you
Yeah.
want to say something before moving to another room?
Thank you.
Thank you. So we're done and we move to other room.
Doc, you want more Purastat?
Okay.